Welcome to the Urology Coding and Reimbursement Podcast, where we help urologists and staff achieve peak economic and practice efficiency so there is time and energy to focus on patient care and a happy life. I'm your host, Scott Painter, with my co-hosts, Mark Painter and Dr. Ray Painter. Welcome to episode 53 of the Urology Coding and Reimbursement Podcast. I'm your host, Scott Painter, with my co-host, Mark Painter and Dr. Ray Painter. And this episode, we welcome Dr. John Lynn again as well. And we appreciate having you. John, it's always great to welcome you on the podcast.
Hey, thank you for having me.
Excellent. And for those of you who don't know Dr. Lynn, he's practices in Gilbert, Arizona, which is outside Phoenix. And is the number one vasectomy doctor in Arizona. So we always like having John on. He's a solo practitioner. So again, thanks for coming. Today, we are going to be discussing the TURBT versus the bladder fulguration and biopsy codes. So John brought this to us again with another discussion, I guess a question on the Thriving Urology Practice Facebook group. And there was a question that circulated and I guess a lot of comments and a lot of discussion. So we wanted to address that, talk about it, give some examples and go through that. So let's get started. And John, do you want to kind of share with us what the question was or the confusion was, and then we'll dive in?
You bet. So bladder cancer is pretty darn common in the U.S. About 83,000 cases, new cases of bladder cancer in the United States. So these codes are going to involve some urology practice at least 83,000 times. And of course, bladder cancer likes to recur, likes to involve different parts of the bladder. So at least 83,000 times a year. This question came from Christine and on February 17th. And she asked, what is the difference between CPT 52004 versus 52224. And what should the note say to distinguish the two? And she just wanted some clarification. And for those of you who have not memorized the entire CPT table, 52204 is cystourethroscopy with biopsy or biopsies. Okay, that's important. And 52224 is cystourethroscopy with fulguration, including cryo or laser surgery or treatment of minor, less than 0.5 centimeter lesion or lesions with or without biopsy. So what's the difference between the two, and what do you need to do to document the performance of these procedures? And then, of course, we can do the comparison between these codes with the TURBT codes. Mark, what do you say?
So we'll start with just the question. All right. So the 52204, which is really about just the biopsy. You're going in, you're taking a specific tissue area within the bladder through the cystoscope. You may have to fulgurate the site after you biopsy it so it doesn't bleed. So it includes, as all of our CPT codes do, when the global, the approach, the diagnostic cysto would be included as well, because you got to find out what area you're going to biopsy, the biopsy, so the taking of the tissue, and the closure, or in this case, the fulguration, so that it's not bleeding. So, but the whole purpose of the procedure is to sample an area of the bladder or areas of the bladder, which is why the parenthetical is there. So that's the 52204. The 52224, which is the fulguration, has of a minor tumor, or and that's of a lesion. Actually, it doesn't say tumor; it says lesion or lesions, and it's with or without biopsy. What that's stating is that what is included in that code, well, actually, let's start with the target end goal of that is that you are trying to remove a a lesion in the bladder by fulgurating it. So you're treating it with straight fulguration. So I probably shouldn't use the word remove. So you're trying to destroy an area of suspicious tissue with fulguration, and it's small, less than a centimeter, and you may or may not biopsy that area, and that's what the with or without biopsy is. So it's not about other parts of the bladder. It's the lesion or lesions that you're trying to fulgurate. So if you're going into the bladder, you're doing a diagnostic cystoscopy, you see two small areas that look suspicious. You fulgurate both of those areas completely, and that's what you're going to do. But before you do that, you take a biopsy of those two areas. Then that would, and then you fulgurate them. That would fit under the 52224. And again, the difference between that code and the 52204 is really your intention. The biopsy itself is only about taking the tissue, and the 52224 is about treating the area that looks suspicious, and it has to be small. So that's kind of that difference between the two. And I'll add, actually, I'll just leave it there. Do you think that makes it clearer for everyone?
I think you said the important word, which was intent. And the question is, how do you convey that intent in the operative note? That is the question. Because when you do a 52204, the bladder biopsy, of course, typically you're fulgurating the base of the biopsy because typically a little bit of bleeding is going to happen. So the confusion for the coder is that, well, he or she sees biopsy and fulguration. Do I use 04 or 24, right? Because there's a significant difference in the RVUs, 2.59 versus 4.05 work RVUs for the 04 versus 24. So it makes a difference, but how does someone convey, what should the note say to distinguish between the two?
Okay. Yeah. And I would recommend to the documenter, so the physician out there, that you really kind of guide your folks. And coding is a team sport. We'll go back to that as always. And if the physician is really good, and I would, it's always good. Most people have a layout to their operative notes where you have, your post-op diagnosis, your pre-op diagnosis, the procedures performed. And that's really that first clue of intent. So most of you dictate your operative notes after the procedure is done. So in the procedures performed, list biopsy if your intention was just to sample tissue, and if the intention was to destroy an area that was of suspicious tissue, then use the fulguration language in that description there. The other place I would encourage you to do that is in your executive summary or findings, whatever you call that kind of summarization of the procedure performed. And again, put your intent in there. And then, of course, the body of the op note needs to support that. So communicate that intent in those areas of your note. So that's the first side. If I'm on the other side, if I am the coder, I'm going to look for key language pieces within the note across the board, and I want them to all match, because that's the other thing that's problematic sometimes, is make sure it all kind of ties together. But if I see that a physician, and so this is another piece hopefully for physicians to clue in on, or the clinician as they're doing this, if the physician tells me that an area of, a 0.35 area of suspicious bladder tissue was biopsied and then the entire lesion was fulgurated, I'm going to move to 52224. If all I say is, biopsy was taken, the area was fulgurated, then I'm not going to move to the 52224. So you want to put in the entire area was fulgurated, or the suspicious lesion was fulgurated in total, something that summarizes that I didn't just stop the bleeding. So that's really kind of that detail level that I'm looking for.
Okay, all right. So you see a solitary tumor that is pretty small. You go in there, and the urologist says the lesion was biopsied and the base was fulgurated. Then you would say that is 52204.
Yeah.
Okay, but how would you? I guess if the intent of the urologist. How do you convey that? I guess an easy example would be a multifocal bladder lesions in the bladder, and you go in there and you say cystourethroscopy was performed, multiple lesions were fulgurated, one of the lesions was biopsied for sampling. I guess that would be pretty easy 52224. Short of that, I bet most urologists out there are just saying, I performed a cystoscopy, looked in the bladder, I biopsied the tumor, and then the lesion was fulgurated. And that leads to a lot of confusion to the coder who may be abstracting from the note. Well, he biopsied it, but then he said he fulgurated it. And they're looking at the description of the CPTs, and they're going to say, well, that's most likely 52224.
Right. It is. And that's why I think the entire area was fulgurated the entire lesion was fulgurated, or the full area was fulgurated. Adding something like that from the physician side is really a good indicator to the billing and coding staff that you want 52224. So don't just skip it. It's, again, intention needs to be listed up front, right? And that's where your procedures performed is important. And that tie-in is going to be the entire area was fulgurated, or, something along the lines that said you did more than just stop the bleeding. And that's why I think really the entire lesion was fulgurated is really the simplest language that you can. It's an easy word to add in. Instead of just the base of the lesion was fulgurated, put the entire lesion was fulgurated. I think that's the simplest solution to all of this.
Yeah, because you can have a small patch that's less than 0.5 centimeters. You take a piece of it for sampling, for biopsy, for pathologic purposes, but then for treatment, you would just fulgurate the entire thing because it looks suspicious. So that will fit a 52224.
Yes.
Yeah.
Yeah, and you could, if you wanted to do a little over, the entire lesion was treated with fulguration. I mean, you could lay it out even further to communicate that intent. So, there are a couple of things that are there, but I would say at the base, that kind of that lowest level requirement is you want to say that the entire lesion was treated or fulgurated, one way or the other, or both treated with fulguration. It's not a hard thing to add to your dictation, and it really will guide your coders as to what they need.
Well, so, I think we beat that one to death.
Yeah, I think we did. And so the only other thing I wanted to add is, usually when we start talking two of the codes within the series, and you kind of listed them out. We've got the 52204, the 14, the 24, the 34, the 35, and the 40.
Yes.
Which, ultimately, when you look at the different descriptions, we've talked about the 04 and the 24. The 52214 is one that is a little bit different in that it doesn't actually list size within the code, whereas the 24, 34, 35, and 40 are specific to size. So the other thing that's interesting, so we'll start with 14. So you'll notice in the description of the 14, it actually it mentions the trigone, bladder neck, prostatic fossa, urethra, or periurethral glands. So what you're talking about with the 1.4 is really a location specification within the code. And so that's really that kind of that differential in the description itself without a size listed. So, and that, sometimes when you have a lesion that kind of starts in the bladder and maybe trickles in to the urethra, that makes it a little bit more difficult. But in those cases, I would go by size and use my, the fact that it originated in the bladder, and I would go by size on up to the 34, 35, 40, one of those codes most likely, even though we kind of moved into a different area. But if you had a lesion in the prostatic fossa, and then in the bladder you had another one that you were treating, now you're talking about using two different codes based on the locations that are there. And you'll need to use that XU modifier or the 59 modifier to split those into different areas. But remember, you're never going to be able to bill the diagnostic in the whole process. And so that's one thing that you want to look at. And then the second thing is in the interest of kind of that full discussion across the board, you do want to look at the difference in 52214, which actually does not list a location. It's one of the 04 and the 24 don't actually specify location. So
the 14 does though. 14 does.
14 does, and so does the 34, 35, and 40. They talk about bladder.
Correct.
So any one of those codes, the 34, 35, or 40, those are for lesions that are primarily or totally in the bladder. And then your 14, you've got different locations, and then that 24 allows you to move around a little bit because it doesn't actually specify location. So location is important, and then of course we all know in urology size does matter.
Size matters.
and nowhere does it matter more than bladder. Than bladder tumors. That's not true. Stones make a difference too. We'll just leave it at that. Yeah. When you're doing PCNLs, but so make sure that size is documented, and make sure you understand location, and that's important to communicate in your documentation, and important to understand when you're reading the documentation.
Okay, so here's a real life type of a scenario. You do a TURBT on a small bladder tumor in the bladder, and you would use 52234, and which is 0.5 to up to 2 centimeters. So there's a tumor there, you treat it there, but then you also have that extension of the tumor in the prostatic urethra. Then you would use 52214 because you biopsied it, right? Or fulgurated it.
So that one's a little trickier because if it's that contiguous lesion, right? So it's really a bladder lesion that creeped in to the prostatic urethra. So that one's, you could argue either way that, maybe I'm dealing with two, but those, when you're talking about, to me, when you look at the NCCI guidelines, that it says they're included, but unbundling is allowed with a modifier. I would look at that as the full size of the lesion itself, because you're not going to say the lesion's stopped and I'm going to just measure it, the part that's in the bladder. That one that kind of is contiguous, I would go with a full size bladder tumor, considering that a bladder tumor that migrated. But separately, and this is coding nuance, if you had a different lesion in the prostatic urethra, then I would use both codes.
That makes sense. So if you have a contiguous lesion, you would just count it as one size and code it as a 52234, 52235, or 52240. But if it's a discontinuous, probably cleaner to do one of those three aforementioned codes and 52214 using a modifier. And one easy way that I found to figure out which code combinations require modifier or not require modifier is the use of the bundling matrix. Scott, can you describe what is a bundling matrix?
Yeah, so in AUA coding today, if you go into AUA coding today, you can click on the bundling matrix tab. And what you're able to do there is enter in all the codes or the procedures that were performed and then click analyze codes. And the bundling matrix will give you a matrix of those codes. And in the intersection in the matrix, it'll tell you if the code can be billed together, can't be billed, or if you need a modifier to bill it. So it's a quick visual of bundling and how codes relate to each other.
Scott, you talk about the matrix. Explain to them what that matrix is that they'll see.
So in what they'll see is it's kind of like a reverse stair step. So it'll be two codes listed, and then in the intersection it'll be a box, and then it'll list all the codes, and it lists all the codes from left to right, top to bottom of the code that has the largest RVU to the smallest RVU, and list the codes that possibly could be billed depending on if a modifier is required or if there is no modifier required. So it gives a quick visual of those codes laid out in an easy to interpret format. So it's really a time saver.
Basically, you can kind of throw in the code. So AUA Coding Today is auacodingtoday.com. And then within AUA Today, codingtoday.com, you can go to an area called the bundling matrix. And within that bundling matrix, you can put in a bunch of codes in any order you want. And then this software or this setup will automatically rank order the CPT codes from the highest RVU to the lowest. So for the biller encoder, it's brainless. You just put in the codes, it's going to spit out which one you should consider listing first and which you can code, which require a modifier to be used with another code. So it's a godsend. It's just amazing.
By the way, John, I saw a discussion on the Thriving Urology Practice Facebook group that was, I briefly saw it. It was somebody telling that they love their books, their coding books. And I think you chimed in and said, no, you need to go online. It just saves you a ton of time. So,
well, no, I said, how do you think I can respond to all of your questions at any time of the day, no matter where I am? But because I use the bundling matrix and the AUA Coding Today to look up codes and things like that. So Mark, you had, let me circle back. Circle back, Saki. Anyway, let me circle back and talk about size. Size in urology matters. Size in kidney stones, size in anything else that the patients tend to ask me almost on a daily basis. Why is it disappearing? But anyway, I digress. Size matters when it comes to TURBTs. I have done these huge multifocal tumors that are beyond 5 centimeters. How would I appropriately code for that when you say size matters?
Yeah. So ultimately, because you're probably talking about everything's done through the scope.
Yes.
And that large bladder tumor has a zero cap, right? And I would also add in there that your medium, you may have medium bladder tumors and small bladder tumors, and they're scattered throughout the bladder, and it takes you forever to get things done. And the way those codes are listed, it's tumors, and that's the interpretation. So that we've gotten from the AUA and the AMA is that you list everything by the largest tumor. So you can only go with one code, regardless of how many tumors are removed and how many variations of size there are. So, if you've got that difficult case, really your only option is the 22 modifier. And so that And I know that, there are people that are a little bit afraid of the 22 modifier, and with reason. And I don't know if afraid is the right word. I would say that ultimately it needs to be used judiciously, because it is defined as an unusual service or procedure. So by definition, it shouldn't happen very often. But as we've talked about before, there are a couple of keys when using that modifier 22. One is your operative note, and again, I would use the executive findings section or the summary or the procedure performed, whatever you call that short window, to explain how many tumors there are and what the complication was. And then I would very importantly add a relative time reference, like this took me twice as long or this took me 3 times as long as the average case, to try and support a request for greater reimbursement for that particular case. So it's important to put the clinical down. It's important to put that relative time reference down. And if you can put it in the summary, it makes it easier for everyone, because generally your own billing staff is overloaded, as everybody is, trying to keep up so that they can get everything done across the board. So they need that information easy to access. And then if the information goes into a payer, those folks are lazy and really not on your side. So the easier you make it, the more chance you have of getting paid better.
Completely agree. So it's describing the extra work that is required, giving a time value, or sometimes you may want to just say, hey, there were bladder. There were multifocal bladder tumors within the bladder, with the largest measuring approximately whatever size. That will really help out the coder to bill out the correct code. And then, or if you have a multifocal tumor with the largest being this size, and you describe the amount of extra time and work required, it's then the modifier 22 would be appropriate. And I would encourage the coders and billers to put that in box 19 of your CMS 1500 form. And we have been very fortunate in that once we put that in, we don't have to provide additional documentation, because we've done it so judiciously in the past. I think the payers realize that we're not going to abuse the modifier 22, so they automatically pay us for a modifier 22 CPT.
Excellent.
I know, and that when you've commented on that in the past, I know a lot of people listening go, "What?"
There's no way.
That always raises a ton of questions, and when you're presenting that at the seminar, and I think that's an important thing to note. And this is kind of goes back to kind of a thread that Ray's always said in the way he approached it is, you got to make sure it's done right with the right documentation, and you question everything and make sure it's all done correctly from the payer's perspective. And once you have that correct documentation, and they see that you're behaving in the way that you should be behaving to properly communicate what you've done, then you're not worth the effort to go after and challenge, because you have all the information and you've provided the right information and documentation, and you have that backup.
I think the payers have very sophisticated machine learning algorithms to figure out which practices have a good understanding of the coding billing rules. And those practices that they're not certain about, they will probably, quote unquote, audit you more by the way of chart requests and things like that. But for the practices who are woke to the coding game, I think they are less likely to bother you. They think that it's not, because you got to keep in mind that for these payers, it's more work for them to have to come back to you, ask for codes and things like that. It's more work than to adjudicate the claim directly on first pass, especially for Medicare at the max. It costs them more money. So if you can provide to them and show them that you know what you're doing, they're more likely to just let the claims pass, and you get paid appropriately. You work happier. and don't have to flex with your coders are going to be a lot happier. So speaking of coding and education, what are some of the resources that PRS has for upcoming training so that we can all understand this game?
All right,
Scott,
glad you asked that. We have several things coming up. Obviously, one of the big events we have is in December. We have our Urology Advanced Coding and Reimbursement Seminar, and also one in late January. So that's December 3rd and 4th, and January 28th and 29th. And in December, it's in Las Vegas, and we are getting together in person. So we're super excited to do that again. And there we this cast of characters that's on the podcast will be there, and we'll have a 2-day seminar and really dive deep into some of the to a lot of the coding and reimbursement topics. So we always have a good crew there, and really get all your questions answered and try and get you the best information possible.
I don't know. My head is kind of dense when it comes to this kind of coding stuff. I personally required multiple exposures to this information to finally one day, oh my gosh, I finally get it. Some people may catch on right away, but there's so many variations, and it's interesting. When I attended as a student, you're teaching the same stuff every year, but it's always changing because the government and the CPT panel are always changing the rules, even though the codes are the same. Blows my mind.
The other thing I will say is that really helps in those interactions with the interactions that with everybody there, because the whole discussion and the nuances of everybody's slightly different take on how the code should be interpreted and how the rules should be interpreted. Those discussions tend to yield a little bit of fruit for everybody, and so it's not just the topic matter, but it's the participation. We like to interact with everybody, and it's really a lot of fun, and ultimately we put it in 2 different spots so that people can choose timing and location. New Orleans and Vegas are nice places to go. So it's really a great event overall. We enjoy it too.
I agree. The interaction among the attendees and the questions raised during the, like say Mark, you could be presenting the same stuff, but then you have people, well, what about this? People will raise their hands and say, well, what about this? Or what if this happens? And that interaction, that discussion fosters much deeper understanding, not just memorizing the codes, but you understand how the codes are applied. And that is key. When you understand something, you're more likely to remember it.
Yeah, agreed. And so the other thing I would add on all of these different topics is, as Ray and Scott have created a virtual course to help further understanding, or to help those folks who come to the seminar or before they come to the seminar to get a better base so that they can participate in those discussions or to follow up, because it's a lot of information in 2 days. And that's, I think, the other thing that most attendees come away with is, I've finally figured out how to use modifier 25, and they're so focused on that they missed out maybe on what 58 means or what the nuances of stone coating is. So it is a big piece of, you can only learn so much, and it is a little bit of a new language. So that base language that's in the virtual course, I think is a good tool to add on as well. And of course, this year, we've now we'll have our first almost full year with the new E&M guidelines. So that obviously was a big change moving forward, and we're starting to get the nuanced questions on how to use the new E&M guidelines. By then, we should have a decent target on what the patterns are for everybody's billing that we can give you. So which I think is going to be good. So I think I'm really looking forward to this year. Plus, it's been it'll have been 2 years
Yeah.
because we couldn't do it last year. So
Yeah. But the virtual event in 2020 was pretty cool too.
But it was
Yes.
there was a different way of doing things. I thought it was pretty cool, and it was fun to do, but it was different, and maybe we could all get used to that. But there was something about it that it just wasn't quite the same, but it was still. But I think I think everybody got used to it, and we did okay, but it wasn't quite the same.
Nope, definitely not. Definitely not. The interaction is a lot more. There's more engagement, I think, when you're in person and you can just raise your hand and go. Zoom is kind of like, well, you have to be acknowledged. You have to mute the mic, and sometimes you forget to mute, and it's kind of clunky.
Yeah, and I'd say the other one is there were a lot of people who decided not to put their cameras on. So although we could hear them, when you can't see them, that the visual, the two cues is much better than just the one.
Yes, and you can read the audience whether or not they understand. The person asking the question really understood.
Yeah.
The question. Yep. Well, wonderful, Ray. Anything to add?
I'd like to kind of emphasize what Mark said. As many of you know, we've been on kind of a mission to improve the actual understanding of the concepts of the coding. And this discussion today has shown, again, the need for the physician to have a base knowledge so that they do know how to document correctly in order to allow the coders to pick the right code. So we're going to start that video education again in the fall. And this year we're going to invite anybody that has taken it in the past to rejoin us, because the idea is to get the knowledge out. And we've had people sign up before that because they were busy or whatever may not have finished. And we've improved in some ways by adding some summarized videos for the person who is really busy. They can hit the summary. But there's a base knowledge that everybody ought to understand. And that goes for the physician and then the coder that looks at the bundling matrix and say, okay, if I can't put a modifier on, I will. That doesn't work. So we want an understanding of when and how to use the modifiers for everybody. So we're going to start this up, and we'll have some live sessions to go with it. So we want to have a good group for discussion.
Well, like it's been said numerous times, it's a team sport. The entire revenue cycle, as you call it, the wheel of fortune, Ray. It's a multi-step process, and every step needs to be accomplished for that dollar to reach the practice. And the easier you can make it, the faster that revenue cycle. And it really literally translates to the bottom line. So the better you understand these rules and the better you can apply these rules, it's literally money in the pocket.
Yeah.
One other thing that John said I want to emphasize, that he had to come to a number of seminars before he finally understood coding. I've always maintained that you can learn the rules, but you may not understand it. But once the light goes on, you can understand. You understand, and coding is not that difficult after you truly understand the concept. I have a joke like that. Maybe I'll tell it at the seminar again this year.
We all know that joke.
Yeah. And so the other thing I'm going to add, and I'm going to sound a little bit like a Geico commercial, but 15%. So that is the really kind of the average that because you don't have everything put together in the whole cycle, the revenue cycle, that practices leave on the table. So same amount of clinical work that you do, but understanding the rules, and this is top to bottom, right? Getting your prior auths, getting your front desks in place, getting your documentation down, using your modifiers, billing the right level. 15%, that for the same amount of work. It's a lift that's there. Now, some of you, it's more, but 15% is kind of that average that gets left on the table.
Wow.
And Mark, don't forget in there the appeal and having the knowledge when to appeal what the payer has denied, because I proved in my practice many years ago when I had a biller that wasn't minding the store and didn't think it was worth their time to appeal the little stuff. When I found out, I changed her value of time immediately, and we started appealing every penny that wasn't paid correctly. And guess what? Within 6 months, my EOB from that payer was squeaky clean. They were right on spot. So if you're not minding the store and let them get away with denials, there's some payers that just deny more and more.
Very true.
All right. Well, I think we're wrapping this episode up. Any other comments? Let's go around the horn. John, any last thoughts?
I just to reiterate what Ray said, Mark said, 15%. So if you're $1 million practice, that's $150,000. You can buy multiple cars for your staff as bonuses if you wish, right? So it's not chump change. And even though this is, lighthearted coding, billing, and it's fun in games, but it translates to dollars. It translates to lives of your practice with the people within your practice and lives of patients. So I always say that your patient success depends on your success. So learn about the rules of coding and billing so you can be successful, so you can take care of your patients.
Very well said. Mark, any last thoughts?
I would say generally no. I think we've covered a lot here, and we'll be back again in a week or so to cover up anything else. But yeah, I mean, we'd love to have you all. We've been on a mission for years to help deal with coding, because the other side of the equation. All right, I'll add this. What you do not only affects you but everybody else. So join the team, right? I mean, if the coding curve is down because people are coding out of fear, it actually slows down the way people get paid everywhere else. So join the team. If you're not going to do it for yourself, do it for your colleagues too.
All right. Well said. Ray, final thoughts?
No, I'm good.
All right. Why don't you take us out then, Ray?
Happy coding.
Thank you for listening to the Urology Coding and Reimbursement Podcast, where we help urologists and their staff maximize income and efficiencies so there's time and energy for patient care and a happy life. Special thanks to Carl Painter for the music today. You can find his music on Spotify under his record label, The Juicery.